I'm going to be talking about brain death or declaration of death by neurological criteria. It's a passion of mine. I work as a neurointensivist in our neuro ICU, and we are often called to consult in other units for brain death and its management. There have been updates to guidelines, both international and in the United States. And so this is a presentation on some of those updates here. I tried to find information that was relevant to Thailand and to the surrounding areas, but some of that information, the files were gone, so I don't know how accurate it is. So please, if I say something that's inaccurate, stop me and say, no, we do things differently here, and we can learn that way. So we're going to be talking about particularly these updated guidelines. We're going to go over some of the components of brain death and DNC testing, identify the confirmatory tests to use and when to use them, and then identify areas where we have a lot of variability in our brain death testing and how we might actually standardize it so that it's a more consistent definition and declaration. So brain death is somewhat common in the United States in terms of it being the cause of death. Around 2% in adult populations, 5% in pediatric in-hospital deaths in the United States. Asian countries and Latin countries, that percentage is much lower. So the last data that I saw was that it was about a 1 in a million death per brain death, according to our guidelines here. It occurs because we have a cerebral insult that is severe and catastrophic. This can be happening because of a primary injury, subarachnoid hemorrhages, traumatic brain injuries, large intracerebral hemorrhages, big strokes, neoplasms as well. And then secondary cause is actually the most common cause, and the primary cause for that is cardiac arrest afterwards. What happens, as you're aware, is you have a massive increase in intracranial pressure. This leads to secondary brain injury that then leads to compromise and finally arrest in the cerebral circulation. You have a loss of brain function that typically progresses from rostral to caudal, and you have the loss of your brainstem functions occurs last. So the medulla and the loss of the respiratory drive is the last cranial nerve to stop functioning. The conception of brain death is somewhat new, although we're getting to the point where it has been around in a description for around the last 100 years. So in 1947, we had our first cardiac defibrillation that brought a patient back from having a cardiac arrest. We had improvements at that time in development of positive pressure ventilation. And so we had the development of an ICU where patients were being admitted to the ICU for critical care management at that time. We had improvements in chest massage, and then we also started developing these external defibrillators. Corresponding around at the same point, we had development of discussions of what coma is. So in 1938, there were studies that were done where they were clamped the carotid arteries and showed that this developed an isoelectric EEG. There were discussions about looking at angiograms and seeing absence of blood flow in patients who had coma. In 1959, we had a description of stages of coma that gave us these 5 stages that we use most often now, from stupor to lethargy to inability to interact, and then stage 5 was absence of reflexes, breathing. And then in 1959 was a paper that was published that described a state of coma that was irreversible, and patients wouldn't recover from that. Same time periods around here, we also had development of ethics and development of talking about end-of-life care. And so there was information that some religious groups put out saying, you know, physicians were not obligated to pursue extraordinary methods. We had discussion about what life and death meant. And all of these came together for us to have a concept around life and death and what kind of care we would be providing to seriously ill patients. Along with that, we also had the development of transplantation. So organ transplantation occurred in 1954 for the first time when it was a transplantation of a kidney. And then we had organ transplantation that happened to the heart. We had cadaver transplantation, liver transplantation that progressed. So this was leading to mostly dead patients who had stopped breathing, that they would take the patient immediately to the OR and take the organ. But there was also some descriptions by some transplant surgeons who were talking about these irreversibly severely brain injured patients that they were taking to the operating room and doing live transplantation. And so all of that led to what is called the Harvard criteria. So the Harvard criteria was a paper done in 1968 where physicians from the Brigham the hospitals in Boston met together, Harvard Medical School, and discussed this irreversible coma. And this paper was the paper that put out the first medical criteria for the consideration of brain death. And then they also defined this for the first time, that this irreversible state of coma was equal to death. That paper subsequently led to some international discussion, and Kansas and Finland in the 1970s put this as medical criteria for brain death. And then the United States by 1981 had created a law that has been adopted by all 50 states. It's called the Uniform Determination of Death Act, which states that an individual who has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. So that determination of death must meet acceptable medical standards. And this has set our legal ground for determination of death by brain criteria since that point. It's still something that overall has been adapted. There are cases of some controversy in the United States related around this declaration here still. So 1981 set our legal precedents, but it wasn't until 1995 that we actually set our medical criteria around what brain death was. So so it was taking the Harvard criteria, evaluating that, made evidence-based analysis for practice guidelines. It formed our medical standard, and then it was left to the hospitals and institutes to determine their local policies. This was reviewed and clarified and changed in 2010. They noted at that point that there was considerable practice variation across different hospitals and institutions. This variation existed in the prerequisites, the number of examinations, core temperature done, and then there were also deficiencies in documentation as well, that they encouraged that we have more robust guidelines in order to reduce the amount of variation here. There have been some evaluations of how brain death has been accepted across different Asian countries here. For the most part, the Asian countries accepted brain death a little bit later. So it was in 1997 that Singapore, Taiwan, and Sri Lanka both all enacted legislation, or 1987, I apologize. However, there has been a gradual change so that most Asian countries now recognize brain death, although it is noted that there's more stringent guidelines compared to the United States. And as I mentioned, there's also a lower rate of brain death certifications in Asian countries compared to the United States. This is not unusual. There is, as I mentioned, a lot of international and variation within the United States. And then there's also international variation as well. A survey of 91 countries in 2013 had differences in examination criteria, in the apnea testing techniques, and ancillary testing requirements. A survey of 500 US institutes showed very similar sorts of variability here. And our latest survey was done in 2020 of 136 countries, where they noted 53 countries across the world did not have any protocols. Factors that may influence the development of different protocols and the acceptance of brain death. One is just the acceptance of brain death as a philosophy, as a pathophysiological event. The acceptance of that in medical institutions as well as in the communities can influence the development of those protocols. Differing religious beliefs can influence that as well. Access to resources, including experts in neurocritical care or neurology. The presence of transplantation also can influence how the community accepts brain death as well. And then there's local and country specific laws that influence this. This is from that paper that I was mentioning from 2020 that looked at protocols across the world. And so these are the protocols from countries in Asia and Pacific. I know Thailand is listed with protocols. Countries without are these ones here. Myanmar, nearby you, did not respond to requests about it and did not state that they had protocols. This is what I was able to find in terms of Thailand laws, and you can tell me how accurate it is. I also don't know if this varies per institution. Is it different at different hospitals here? So my understanding is that brain death was endorsed by the General Medical Council in 1989. And the certification requires 2 different clinical examinations that show an absence of brainstem reflexes that are performed at least 6 hours apart. And confirmatory test is not required, but can be done if needed. My understanding is also that 3 doctors are involved in this process. The attending doctor, a neurologist, and a neurosurgeon, and the director of the hospital or their representative. Does this sound accurate?
Yeah.
Yes. Okay.
I'm not sure what you mean by mandatory confirmatory test. Is it something like an apnea test?
No, the confirmatory test would be radiological or electrophysiological, EEG.
Right.
So from my understanding is that the confirmatory tests are not required. There are some countries that say you have to do the physical exam, apnea test, and a EEG or an image modality.
Why in medical council already revised these declarations 2 times.
2 times?
So now, right now, they have a criteria. This criteria what written in 2012,
2012?
the last one.
That's the last time it was revised?
Yep.
Great. Well, there are some new guidelines and maybe we ought to update them because,
Not much change, but not much change.
all right. variability in different countries, variability across organizations. This was a study, as I mentioned, in 2019 that looked at our variability in physician practices for their brain death declaration. We had variations in the type of physical exam that we did. So this was a study of 70 responders, and they showed that across those 70 responders, fewer did peripheral pain. Not all of them did a cough assessment. An apnea test was only performed about by 60 of the responders here. The pupillary response was done pretty much 100% of the time, as was the gag. But there was variation in the physical exam components here. There was also variation in the ancillary tests or confirmatory tests that were done. So a percentage of the responders, this was they defined it as automatic or as needed. So EEG was done automatically by over 10% of the responders. Nuclear medicine scans were done much more frequently as needed. It was required in about 10% as well. CT MRA or CT angio MRA was also used, angiogram, TCDs, and then there's a smaller component of other ones as well. There are consequences in us having variations in our practice in our declaration of death here. It leads to deficiencies in our quality of care. There's concerns about medical malpractice and the inappropriate termination of a living patient if we are inaccurate in determining death here. And then there's it erodes our trust, the public's trust in us as institutions if we have patients who are declared brain dead who then recover, because it attacks the validity of the definition of brain death. It erodes that trust, and it destroys this notion of the irreversibility here. This has actually been something that has been hotly contentious in the United States right now. So a few months ago, there was a publication that was sent to our United States Congress. They had a meeting and they had a nurse who came and reported that there was a patient that their hospital had declared as brain dead. They had taken them to the OR and the patient moved on the table. And the surgeon said, there is no way I'm doing surgery here. The transplant network was like, well, maybe we should find another surgeon. Bad move on their part. So it was just very poorly done. And this is the guy. So he had a drug overdose. He was sedated and he was inaccurately declared dead. Now, this is in all of our newspapers about this patient who was declared dead and who recovered, and the doctors were just wanting his organs. So it really erodes our trust and our ability to have conversations with our families when we aren't accurately putting forth our exam, our apnea, and making sure that when we are declaring these patients dead, that they are truly dead. So in response to all of the variations, the AAN, American Academy of Neurology, in 2018 put together groups saying we need to be much more accurate on our declaration. So they advocated for uniform policies. They advocated and created different education initiatives so that there are different toolbox available. They promoted brain death testing and credentialing programs, and then they collaborated with pediatric community to try to create one overall set of guidelines. And then they have been advocating for a consistent legal approach to brain death. This led to what is known as the World Brain Death Project. So the World Brain Death Project was a consortium a collaboration of 27 international medical societies that came together to try to develop a comprehensive minimal standard for brain death declaration, achieve international harmonization, and improve the rigor and minimize diagnostic errors for brain death and death by neurological criteria. There are 17 supplements that were included in this. I highly recommend that you all find this article because it is just rich with resources and rich with information here. So the international guidelines determined that that we should have define brain death as an equal to death by neurological criteria. It is a single brain-based definition of death, meaning that it is when the brain dies, that this is when we are calling it death. You can die because of no oxygen going to the brain because of your heart or your lungs stopping, or no oxygen going to your brain because you have no blood flow to your brain. They wanted to avoid anatomical specifications of death and emphasize really that we are talking about our overall function of our death rather than electrical activity. They encouraged all hospital policies to adhere to these most up-to-date national standards. They recommended strongly that clinical checklists be implemented and referred to during the declaration, and that training and credentialing should be happening to the clinicians who are responsible for declaration. So that was 2020 with the World Brain Death Criteria. And the United States, through the American Academy of Neurology, just recently in 2023, a year ago, created another set of guidelines that is the guidelines for the United States, which is a combined guideline set for pediatrics and adult brain death here. As I mentioned, it's collaboration between multiple different societies here. And it was an update to that 2011 adult guidelines. Pediatrics had last been updated in 2011. They noted that most of the requirements were the same for all ages. There are a few child-specific areas because of physiological differences. The open fontanelle and unfused surfaces mean that you can have a reduction in the rise in intracranial pressure that can then decrease, and the patient may actually do better than what you think. And brain stems in infants are more resistant to hypoxic injuries as well. There's also some historical context that led the pediatric guidelines to having 2 different examinations and 2 different apnea tests. Changes that are within the World Brain Death Guidelines as well as the new AANs are, one, brain death be more referred to as brain death / death by neurological criteria. Brain death is the colloquial term. We're all familiar with it, but we really want to emphasize that this is an equivalent death as to cardiopulmonary criteria here. There's an emphasis on permanent rather than irreversible. So irreversible means that we cannot reverse, that the loss of function cannot resume spontaneously and cannot be restored through intervention. And permanent is more of, will not resume spontaneously, and we're not going to be using medical interventions to attempt the restoration of function. That looks really hard to read here. I encourage you to actually read the article, but this was trying to highlight some of the changes here that came together. One of the things is that you need to make sure that the etiology of the brain injury, that you should not be performing brain death evaluation if there is any evidence of consciousness, if there is any evidence of intoxication going on that could be mimicking your exam. You need to make sure that, so have an explanation for it. They recommend, rather than doing 2 different examinations, they recommend for a longer observation period to ensure that the injury is permanent and not reversible. And so for at least 24 hours after a hypoxic ischemic event, and based on the pathophysiology of your other injury, you should also be considering a longer time of observation before doing the test. You need to make sure that the injury is severe enough and permanent, that your neuroimaging is supporting a diagnosis of brain death, or that you have evidence through your extraventricular device and the monitoring of your ICPs that you have elevated intracranial pressures. And then you need to also just make sure that all of your laboratory parameters are in an area that would not be causing a mimic of brain death here. So yes, so changes to the prerequisites: observation for at least 24 hours after a hypoxic injury or a sufficient amount of time based on the pathophysiology. Allow time for your surgical or medical interventions to ensure that there's no recovery. And don't perform the exam or stop it if you see any kind of brainstem reflexes. I think making sure that metabolic derangements, intoxications, medications have been excluded, adequately corrected, or eliminated. They specified that neuroendocrine function does not preclude the diagnosis of brain death or DNC. Diabetes insipidus is absent in around 50% of patients who meet criteria for brain death, and that there's a unique blood supply through the hypophyseal artery underneath the dura in a portion of these patients here. Pregnancy is a contraindication, and you can also perform brain death testing, apnea testing on patients who are on ECMO. The changes to the clinical exam. So they recommended that you only need one examination. However, they stated that a second examination that is performed independently may decrease the risk of a false positive determination of diagnostic error. They allowed advanced practice providers to also perform brain death if they have been credentialed and trained. Residents and fellows need to be supervised. They specified that you need to have a blood pressure of a greater than 100 for your systolic blood pressure, and have a MAP greater than 75 to ensure that you have, if it's present, cerebral perfusion. The temperature needs to be greater than 36 degrees Celsius, and to wait at least 24 hours after rewarming if the core body temperature has been lower than that. They changed the apnea, that the target is a PCO2 of 35 to 45. However, if your patient is a chronic retainer, then targeting your chronic baseline levels is appropriate here. You want to have an arterial pH between 7.35 to 7.45. Oxygenate for at least 10 minutes with 100% oxygen on the ventilator, and then provide apneic oxygenation by stopping the mechanical mandatory ventilation. This can be done by a couple of different ways. So at our hospital, we have ventilators that we can put the patient on spontaneous, and it doesn't trigger a backup rate. So we keep them on continuous pressure and continuous oxygenation directly on the ventilator, and don't disconnect them. You can also do it with an insufflation catheter that is going down the endotracheal tube, or you can use a flow inflating resuscitation bag. Do you guys know what you use here?
I think it's very similar for the apnea test. We usually disconnect the ventilator.
You disconnect.
We put the NG tube down to the carina. We supply oxygen.
And you supply oxygen down there, yes.
Then we do zero arterial blood gas. And we are looking for PM, the carbon dioxide to rise above 60.
Yes.
Starting with 40, and if it goes up to 60, it's a positive test.
Yes.
Yeah.
Very similar.
Very similar.
So the guidelines say a increase of a PCO2 greater than 60, but it also needs to be greater than 20 above their baseline. So it's an and there, and the pH needs to be less than 7.30. So they felt very strongly that it is both a CO2 and a pH that is going to influence your respiratory drive.
pH is not in here. So.
Yeah. It's not in ours either. So we are in the process of revising ours. The ancillary testing. So as I mentioned earlier, ancillary testing had included EEG. There was nuclear medicine testing as well as cerebral catheter angiography. The changes to the World Brain Death Project guidelines was that EEG should not be used routinely. If EEG is the only modality available, using it and SSEPs as well as auditory evoked potentials and visual evoked potentials as well to determine that you have so the issue is that the EEG does not measure your brainstem function. And so the combination of the EEG plus your evoked potentials will assess both cranial as well as brainstem reflexes there. So the AAN guidelines that were released in 2023 removed EEG and SSEPs entirely. So they say that those are no longer accepted in the United States as testing. And the reason why is that you can have patients who have an absent EEG because of sedation or absence of your SSEPs. And you're doing these in cases where your testing and your apnea is not enough. And so having a patient who may have some sedation that's causing a reduction in your EEG, the EEG isn't going to confirm that they are truly dead. So they recommend now a 4-vessel angiogram. You can do a radionuclide cerebral blood flow scan, or you can do transcranial Dopplers ultrasound in adult patients only. Is the recommendation. That can be complicated because if you have any kind of cranial injury itself, that can affect your TCD results. And a certain percentage of the population, at least 20%, do not actually have temporal windows. And so therefore the TCDs aren't useful in that population. So we've pretty much moved away from TCDs entirely because there's just too much variability in who would be able to have it. They strongly recommended that CT angio and MR angio not be included as well because they are inadequately studied currently. There can be inaccuracy in the timing of the boluses. If you have a patient who has decreased heart function, you know that changes how your perfusion is happening with the dye as it is. And again, MRI and MRA are not adequately studied either.
May I ask, actually, I know for the EEG, it may make us like a false interpretation, right? I mean, there's some,
Right.
if there's some way, but the patient already brain dead, right? Yeah.
Yes. So that's the other issue with EEG is that your machines around it can cause interference. And so again, it makes it very challenging to interpret it. This is so if you look at the AAN, they've created an algorithm that you can go through to determine whether or not your patient is meeting criteria to undergo brain death testing as it is. So they'll have you walk through. It's a website. I'll show you in a second, a website where you can click on each one saying, is my patient meeting these criteria? And it'll make recommendations as to whether or not to do the testing. And then once you have met the criteria, then it'll go through and put in all of the information of the results that you're seeing, and it'll again confirm with you of whether or not that you are meeting brain death criteria for the declaration. This is a really, yeah, you can't read it. I apologize. But it's all available on the website. Pediatric considerations. So brain death cannot be performed reliably on patients who are less than 37 weeks gestation. You need to wait at least 48 hours after an acute brain injury in infants who are less than 24 months old, 24 hours for acute hypoxia, and they are still recommending having 2 physicians perform a separate exam 12 hours apart with 2 apnea tests after each examination. And again, this pathway that you can see elsewhere. There was a lot of discussion in our in the guidelines, both in the World Brain Death Project as well as the AAN, as to whether or not you need to seek consent from your family members. Can I ask if that's a requirement here? Do you need to have consent from families?
Yeah.
Yes.
Yes. So in the United States, most neurologists believe that you do not need to have consent because it is the same as death, and we don't consent to determine whether or not somebody is dead by listening to their hearts or lungs. We go in and say, I'm so sorry, it looks like your loved one has died, and we perform our exam and we check it off whether or not the family wants us to or not. And so the AAN guidelines said that the death by this criteria is the same medically and legally to death by cardiopulmonary, and so you don't need to obtain consent. However, there have been many states in the United States and countries who have said consent is required. So in the United States, Montana, Kansas, and California, you have to obtain consent from family members before going forward with your testing.
Actually, that's the opposite. Sometimes the relative want us to, perform the brain death examination. So I mean, sometimes patients just like, we think maybe they're brain dead, but the relative not request.
Mm-hmm.
So if no organ transplant, then there's nothing doing. But if they request, then I don't.
But if there's, so we have tried to move away from doing brain death testing in patients that only in patients who are going for transplantation, because it was leading to this sort of view of it's only relevant in patients who we are trying to get organs. And so our movement has been, if we think that they meet criteria, we should be doing brain death testing in all of those patients, regardless of their organ transplant viability. So that has been a change in our culture and a change of how we approach our testing here. They did include in these guidelines and in the World Brain Death Project that we need to be making reasonable efforts to inform family about our plans for testing. There was a case in New York City about a patient who came in who progressed to brain death. The family were processing it and trying to talk to their rabbi about this. They went to synagogue, and while they were in synagogue, the physicians went in and did the testing and declared him dead and told the family when they arrived. The family sued. He had a death certificate that was issued. The family sued, got him transported to a nearby hospital. The court at that time said that the hospital had performed this testing without letting the family know, and therefore that testing and the declaration was void. And so it has made it so that we definitely need to be having conversations with families, not necessarily consenting them, but telling them of what we're doing and having them informed and involved in the process here. There are families who object to brain death, both as a concept as well as the testing. And there's a lack of guidance for clinicians on how to manage these objections. When the family comes and says, I don't want to do brain death testing, or I don't believe those results and I want to continue with the ventilatory support. There's very little guidance in there, and it really is dependent at this point on your institution establishing policies for getting second opinions, for transferring to another hospital, and for how long you might continue that support.
So if you issue already the date certificate, do you like stop everything
We do,
early at
yes.
that time, at that point, right?
Yeah, so our policy at this point, we have it set up that we do the testing again without consent. If the testing confirms brain death, that's the time of death, and we allow a period of 6 hours for families to gather and have their chance to say goodbye. If families disagree, then we have policies to involve our ethics and our legal team to help support the physicians in creating a timetable of either finding another hospital to accept the patient or continuing our conversations with the family.
That's
I have a question.
Yes.
If the patient have many children, but they haven't decided which one will be their legal proxy,
Yes,
how would you determine that whose decision is the final
yes.
decision?
Uh-huh. So so in Oregon, our laws for family decision makers, it defaults to the spouse and then to the adult children, and it's all the adult children. So we have to get consensus from adult children before moving forward with medical decisions. Again, because we don't require consent for this, we are able to do the testing and inform families rather than getting consent from all of those adult children.
So all you need is just declare to the family member. You
Yes.
don't have to decide that you get the clearance from the so-called legal
Right.
proxy first, right?
I don't have to get clearance from them. That being said, I have certainly had cases where my families have been very much disagreeing with it, of the concept of brain death. And I have navigated that by including my families in my declaration. So I have my families come into the room when I'm doing the examination and go through it. I keep a medical student or a resident beside me so that I can explain every step that I'm doing, to educate my resident, but also to educate the family. And then I also have them in the room when we do the apnea test. We do our apnea test for 10 minutes. And I can tell you that there are very few families who, after being there for 10 minutes and not seeing their loved one breathe for 10 minutes, who don't accept it after that. We all, we all breathe within 10 minutes, and not taking a single breath, the families realize that what we are talking about and the severity of it.
So does the insurance company involved with this?
They're not really, no. Insurance companies, they don't get involved in these kind of decisions here. So it can get complicated if a patient has been declared dead in one state and transferred to another hospital. So New Jersey has a religious objection to brain death testing, or brain death declaration. So if you state that you have a religious belief against it, they do not allow testing in that state. So there was a famous case. I don't know if you all heard about it, but it was of a little girl who lived who was in California. Her name was Jahi McMath, and she underwent a tonsillectomy and bled afterwards and had a hypoxic injury. And so the doctors and the doctors did the testing. They and the nurses went and talked to the family about this. At the testing saying that this is conclusive with brain death, and the family disagreed and sued. So the state of California backed the doctors saying that this was a legal definition of death, that they met the criteria. They issued a death certificate, but they also told the family that if they could find a hospital, they could transfer the patient. So they issued a death certificate in California, and the family found a hospital in New Jersey to transfer her. So she was transferred across the country to New Jersey and was in a hospital there for the rest of her somatic life until her body died 4 years later. It was a very long time.
Now,
And so she has 2 death certificates. She has one in California and one in New Jersey. The insurance company in New Jersey would not pay for her medical care because she had a death certificate. So it was expensive, and it was all based on private care. There were different charity cases, charity companies who supported her care. The World Brain Death Project suggests that hospitals, in order to overcome some of these requests for accommodations or just resistance toward brain death, work with our local religious and cultural leaders, learn about our communities, and proactively discuss brain death with our religious leaders so that they are able to have conversations with their people that they oversee. We need to be trained in cultural sensitivity and communication. When we look at a lot of these accommodation requests, there is a lot of frustration in how we are communicating with families over death. And that really is probably the heart of the reasons of why they push back on some of these areas here. Family support, education be provided. Again, they do recommend that we invite our families into the testing that we do. And we should also be creating guidance for requests. So I mentioned that if you want to, this website here, this is where you can actually go through that interactive tool to and the algorithm to go through and say, is my patient meeting brain health criteria, and what's the next step I should be doing? There's also this brain death toolkit that was developed by the Neurocritical Care Society for education for physicians and other providers, so that we are all up to date with the standards for testing here. And then if you want to get really knowledgeable about it, there is a death by neurological criteria course that is also hosted by the Neurocritical Care Society, where you can, for several hours, you can listen to different people, you can take a test, and you can become credentialed in brain death declaration. So OHSU, we revised our policy based on the World Brain Death Project in 2021. The reason why we did so is because we actually had 2 different cases where we had been improper in our testing. And while our patients hadn't gone all the way down to the OR before we did organ procurement and they moved, there was some return of cranial nerve reflexes prior to that happening, and it made everybody very nervous, and we realized that we were being very inconsistent in how we were doing our testing. The big thing was that there was inadequate observation time. So we were doing our testing on patients just a few hours after they had arrived in the hospital when they were still severely injured from everything. And so we have extended it out so that we have at least 24 hours after their insult before we'll actually declare there. We have decided that our policy has two different physicians who do the testing. They are independent examinations. So one goes in and then the next follows after that. We don't have a time limit between them, so it can be done at any time, but they need to be independently done so that each of them are following that. Our apnea testing, as I mentioned, we do it on a ventilator where we actually don't have to disconnect them from the ventilator. And all of our respiratory therapists have been trained on how to do that. We have at the time we specified that we could do EEG plus our evoked potentials, and we're removing that from our guidelines now, and we're trying to revise them to our 2023 guidelines. So I left some questions here of, we talked about your hospital policies and your checklist here. Did this bring up anything as to what you might need to change to make your hospital and institution up to the Brain Death Project guidelines here? Do you need to be making changes in your ancillary testing like we did? And do you have guidelines for accommodation requests either?
For some patients, if they have like acute renal failure, then they have very hard breathing. So I think if you want to declare, but you have to collect everything, right? You have to
Yes.
analysis, you have to
No,
collect the low sodium, everything, right?
so we have, let me see if I can. I'm going to show you our guidelines here real quickly. So we have three different okay. So we have a policy here, which hopefully it comes up here, which outlines who can perform it, the responsibilities, and then our requirements here for prerequisites and how the examination should be done. We put in here, as I said, our EEG, we're removing this portion here of what kind of confirmatory tests we can do. And then this is where we have outlined how long we could continue somatic support for accommodations for families here. So we have our policy here, and then we have two different supporting documents. We have a checklist that is used. Should be our checklist. Our checklist that is used for our for the examination, and then we have translated this checklist into a phrase that goes into all of our documentation and our notes and our electronic medical record here. So here's the things where our electrolytes that we have. So our pH needs to be greater than 7.2. Again, we're going to be changing this. Sodium greater than 120 or less than 170. Calcium needs to be greater than 8. Glucose greater than 70 and less than 300. And other ones should be reviewed and abnormalities corrected. If we aren't meeting these criteria, then we will try to correct them. If we are unable to correct them, say a patient who has acute renal failure or has renal failure and has a creatinine and a BUN that are very elevated, that you're not going to be able to correct without putting them on CERT, which you don't want to be doing on a patient who you think is dead. We will do confirmatory testing. So those are the time when we will move forward and do our ancillary testing with angiography and or with the nuclear medicine test. So this is our confirmatory test. We put here confounding conditions that we can't resolve them if we're unable to complete all of our clinical exam, if there's any kind of uncertainty here, if they have a infratentorial lesion here, or if we needed to assist in our family's understanding of brain death here. And then lastly, we have this one here, I think. We wrote out a complete description of all of our diagnostic criteria and the reasons why. And then we also, excuse me, one second. We also created a walkthrough of the entire neurological exam and the expected findings and what you would see if it was not consistent with brain death and what you would see if it was consistent with brain death. So we included information about, if we were seeing things, so response is consistent for a patient that we are doing stimulation. You should not be seeing any kind of grimacing or facial movement or motor responses other than your spinally mediated reflexes. You shouldn't have any kind of movement when you're doing noxious stimulation above the foramen magnum in the face. So we did that for every step of the cranial nerve examination and the neuro exam. And then again, we did the same sort of thing with a breakdown for the apnea testing for our physicians, our nurses, and our respiratory therapists. So we have all of these resources available for everybody who is doing the declaration here. And we expect them to be referring to them when they do their declarations.
For the doctor that goes in different period of time to test the patient, but our policy, I think, to doctor we examine the patient at the same
time
to witness that
Mhm.
and then we have to return back after 6 hours again
and do it then.
I don't know, what do you think?
Yeah, so
like one at a time.
So I think there is. I had a couple of cases here that I was gonna walk through, but I was consulted for being a second examiner a couple of times on some patients where the ICU team in the other unit had done the first exam, and they asked me to come in and do the second exam. And when I was in there and did my second exam with them, I had a different response than what they got. So they had no movements at all, but when I was performing it, I saw some movements that I wasn't sure whether or not they were spinally mediated or not. And so it led to different kind of testing that we did later.
Did you do video record? Video record?
Did I video record? Oh, I should have. Yeah, I need to do more. We have some patient privacy laws that prevent us from recording our patients without explicit written consent for it. So I would, it's a really great point of, should we be doing some recording so that others can see what we're seeing and know what we're doing differently. Let's see if I can. If you want to go through these cases real quick, I can. We're a little bit. I'm a little over, but I don't think I'm terribly over here. So these are all patients that I've been involved in. This first one was a young man who came in with the worst headache of life, nausea, severe neck pain, and the imaging showed this abnormality here It's a very large arterial venous malformation. We took him to angiogram. It showed multiple feeders. They were not able to coil it. They took him to the OR because he had bleeding from it. And he had the most profound bleeding that I have ever seen. He lost 20 liters of blood during the surgery. He had just transfusion after transfusion that entire time. They noted multiple fragile diffuse feeders throughout that they were unable to treat. He came back. This was the first CT. This is the second CT several hours later. And this is the third one here where they took him to the OR again to evacuate that clot. I see you all wincing because yes. So they were able to evacuate that clot. And when they evacuated it, they said, we got hemostasis, good resection was performed, and we noted that we could see pulsatile brain underneath the dura. So at that point, even though this had been very large, the brain above supratentorially seemed to be intact. He never woke up though. We saw some head movements that were like some twitching kind of movements there initially when he came back. We threw on an EEG that showed some low amplitude delta activity. There was some polymorphic theta activity, some asynchronous faster frequencies, all consistent with the severe global encephalopathy. Placed in EVD, his ICPs were initially elevated to 30, but they flushed it and the ICPs went down into the low teens, and all of that seemed to be better. He didn't wake up. We held propofol after that, didn't stop it. And when we did a cranial nerve examination and all of our exams, we saw no cranial nerve movements. He was not overbreathing the ventilator, and there was no movement to noxious stimulation. So my question to you on this patient, would you perform a neurological exam and apnea testing to confirm brain death? Would you perform the neurological exam, apnea testing, and do confirmatory testing? Or does the patient not meet prerequisite criteria for it and no testing should be performed?
Go A.
They choose A.
So the answer is C. C. So he has severe brainstem injury, but when we have an EEG, we don't have any evidence of supratentorial injury that would be consistent of not having any blood flow to the cerebrum. So yes, so he was not brain dead. He had severe brainstem injury that caused the lack of his reticular activating system was shut down because of that. He was in a coma that was likely irreversible. So his likelihood of recovering was very low, but he did not meet brain death testing. So I talked to the family. So he had no ICP elevation. We didn't have an identification of an injury to the whole brain. Our EEG showed activity. So the EEG cannot confirm brain death, but if you see activity, that is not brain death. So I can talk to the family about all of this. They elected to pursue comfort care, and we do organ donation after cardiac arrest in the OR. So we withdraw mechanical support. We allow the patient to die on the OR table, and then we do organ procurement after that. I don't know if that's one of your policies here either. Number 2 patient was a patient who came in who collapsed pulses, diffuse subarachnoid hemorrhage. He had a progressively worsening exam, refractory ICPs, and a CT that showed extensive infarcts. I did brain death testing and the clinical exam, no movement to noxious stimulation, no cranial nerve reflexes. But on my apnea test, I had these 3 episodes, a very small chest movement, and there was this slight expulsion of air. Just this not really a breath, but not really not a breath either. It was very, very odd. When I continued doing the exam through the whole thing. My starting pH was 7.39. It ended at 7.2, PCO2 37 to 63. So met all of our criteria for declaration here. But those three little small chest movements. So what would you do? What do you think? So my ABG and my testing meets brain death criteria, and I should declare the time of death at that point. The respirations aren't consistent with brain death. Consider retesting in the future. I still have some blood flow going to the medulla, or I'm uncertain and I should be doing confirmatory testing. What would you do?
See again.
See? Yeah. Yeah, so this was several years ago. I'll admit, I declared death. And I think at this point, I would go back and do confirmatory tests. So the guidelines mention this respiratory-like movement where you have an adduction of both shoulders coming forward, followed by a slow cough-like movement that can expel some air. That is finally mediated. I thought that was what was going on. I probably should have done confirmatory testing to confirm that. Confirmatory testing could be done there. Third patient, I have a 16-year-old male shot in the head, drive-by shooting. The trauma surgeon performed the first neurological exam. They did the apnea test and then asked me to come in and perform the second exam. When I examined them, I had no brainstem reflexes, no response to central stimulation, nothing temporal mandibular or nasal tickle. So no central stimulation kind of movements, but on peripheral examination, I had this very slight pronation and extension of the right extremity. And I mean, we're talking tiny little movements there. Just to nail value stimulation that could be repeated pretty much anytime I did that particular nail bed stimulation. So perform the apnea test as movements are spinal, do a confirmatory test, perform our confirmatory test of absent blood flow, document our time of death, do it. If we have absent blood flow, go ahead and perform an apnea test or stop testing as our patient does not meet brain death criteria. So this patient is 16. So there is a requirement for 2 exams and 2 apnea exams in the United States.
In United States or in Portland, in state of Oregon?
In the United States. The pediatric have 2 examinations and 2 apnea tests that need to be done 12 hours apart.
And pediatrics in the US cut off is what?
18 years old. Yeah, so at 16, he is still considered a child.
Get driver's license, right?
He gets a driver's license.
How can he drive? I mean, 16.
I know, he's still a child. It doesn't make sense.
It's going to happen in where? New York or drive-by shooter?
No, it was in Portland.
In Poland, really?
Yeah.
Oh,
We do, unfortunately. So there were a few things to learn here. One, they were doing testing back and forth, not in the correct order. We have a tendency at OHSU that I am trying to educate. They do the confirmatory test first, just to see whether or not there's blood flow, and it is a clinical examination here. And so this patient, I finished my neurological exam. We did an apnea test. We did a confirmatory test that showed that those were spinally mediated movements. So the nuclear medicine test was empty. And then so after that, we declared death on him. Last case here, and then I'll turn it over to my colleagues here. We have a 29-year-old who came in with asthma and seizures. She was found down at home seizing, severe hypoxemia, 50% hypotension down into the 70s. at this time, she was diagnosed with COVID. So just very sick. 3 days later, the team noticed that she had loss of all brainstem reflexes. The family was adamant that all care continued, but when we approached them with testing, they said, again, I don't consent, I tell them, and they agreed to be in the room when we did it. So the MICU attending did the first examination, which showed coma, no kind of movements or no brainstem reflexes, and no motor responses as well. And I came in to follow that, and I noted a faint movement of the right big toe to peripheral stimulation. Faint. Again, just a sort of, this right big toe kind of curled and moved out. That was not something that I would see in a patient who I thought that this was reflexes. So because of the SARS, because of COVID, we weren't able to do apnea test. So B. Well, I actually performed a confirmatory test because this toe movement, I'm like, I don't know what this toe movement is. And this is a nuclear medicine that showed she had uptake through her brain. So she was not dead. So this one little toe movement showed that her brain was still having blood flow. And so I had a conversation with the family they were very ecstatic when I said, oh, she's not brain dead. But then I had this conversation of the only movement that I saw was a toe movement after this is suggestive of a very severe illness and her lungs are very sick. And the family actually said, okay, so it is time for us to say goodbye. And they were actually really appreciative of having been there in the exam to see how much I was doing to get even a small little movement from her. I have had to go back to my other teams to tell them that they need to be much more aggressive about their noxious stimulation. They have a tendency to be just a gentle kind of press, and we really need to be very firm in order to make sure that we are looking for all kinds of movement there. And then confirmatory tests can be done if you are uncertain on how to interpret it and can help us determine patients who aren't actually brain dead or are brain dead here. And there's the end of my.
So means that the last case, the family said that, let's say.
They did. They said.
So there is the evidence of the blood flow in the brain.
They did. Yes. Because we were able to tell them of how sick she was overall. Her brain injury showed was severe. So on the CT scan, you could see multiple areas that had been involved because of the hypoxemia. So while there was blood flow, the tissue was all damaged.
So which nuclear medicine you use PET?
Yeah.
PET or what? Yeah.
We use PET the majority of times. It's something that our nuclear medicine team are available in the hospital all the time, and so we're able to get it very rapidly. We have it, and we're able to have it interpreted within a few hours. Our cerebral angiogram, it's a lot more complex getting our patients to the angio suite. There's always competition because our stroke team loves to do interventions, and so it's harder for us to get the angiograms.
So like a FDG PET from.
Yeah. Any question from the round table from the video conference for Dr. Julia? Very experienced.
So actually, I don't know. I've asked about insurance again. When you perform the brain dead examination, many times, and the insurance will pay for.
Yes. So I document all of my time as critical care time because my overall approach is I am doing this testing to see if the patient is alive. That is, my approach is the patient is alive, and I am doing the test to determine whether or not that is the case. So all of my documentation is I suspect that the patient has progressed to brain death, but I don't know that for sure until I do these tests. So I will do the tests. I bill as critical care for every element of it. And then, and then after the declaration of death, then that's when you can't bill after that for critical care.
So we don't need the lawyer in the process, right? I mean, just only the medical, right?
I think that I believe firmly that this is a medical decision. This is a medical declaration, and our legal system need to they need to take a step back. They need to not be involved in this.
I mean, I think so. But they will involve after this too.
That they are very much that Kentucky case that I showed, they are very, very involved in that. So
Thank you very much, Dr. Julia. We learned a lot. A lot of various cases you show us today. And the next one will be the learning from Dr. Larson.